Hi, you guys. It's Dr. Baker Townsend, and I want to talk to you about maternal and fetal nutrition. We're going to be reviewing our chapter 15 in our louder milk text. So our learning objectives today, we want to talk about weight gain during pregnancy, compare energy sources such as vitamins, fats, minerals. We're going to look at what foods we want to recommend for patients to eat, which are nutrient dense. Look at supplements that we're going to give in pregnancy. Look at nutritional risk during pregnancy. Talk about women from ethnic cultures in which this is a very important topic because women have different ideas of what is normal for them to eat based on their culture. So if you notice any cultural variance, make sure that you get a dietary log so that you can look at what they're eating and making sure it has enough calories and making sure that there is nothing that would harm her or the baby. To discuss nutritional considerations for women who are obese and have had bariatric surgery, and that's on page 345. Just talk about that real quick. Of course, we know that the heavier you are, the more estrogen you store, and the greater your risk for a blood clot. So they have so many risks. They have infection risk, they have preterm labor risk, they have diabetes risk, hypertension risk. So you need to make sure that you limit their risk as much as possible for the baby, because they already have all these other maternal risks, and make sure that you do a dietary evaluation of what she's eating, because we don't want to make more risk. We don't want her to gain too much. At the same time, we want her to meet her weight gain goals for the baby. So we'll have to, I want you to look at that as well. And then food safety precautions, we'll talk about those. Lastly, we're going to do nutritional assessment looking at height and weight. You want to make sure that the patient, you get a good height, weight, and calculate a BMI for this patient. For testing purposes, I'm not going to hold you to a BMI, but for clinical purposes, they need a BMI so that we can make sure they're gaining enough weight for that particular BMI. We want to provide interventions that are appropriate for their weight gain, meaning as the nurse, you should be able to look at weight gain patterns, and you should be able to say if these are on track, if they're too low, or if they're too high. And then of course you can balance if it's too high with a reduction in some of the calories and some physical activity. So you need to be able to assess that. On your test, I will definitely put scenarios where you will look at weight gains by the woman during the individual trimesters, and you will have to counsel her on if these are appropriate weight gains. Okay, so a healthy diet, we need dense, nutrient-dense foods. That would be vegetables. Our favorite go-to is dark green leafy vegetable. You can never go wrong with a dark green leafy vegetable. It has a lot of iron in it. It's just packed dense with nutrients. The first trimester is the most vulnerable time because of the teratogenic risk. We definitely want them, when they are eating vegetables, to make sure that they wash the vegetables very well so that they do not obtain a bacterial infection. We want to make sure that before pregnancy and all the way during pregnancy that they have appropriate folic acid intake. Folic acid, as you know, is a B vitamin, and we have fortified a lot of our foods with folic acid. However, you need to make sure that you push and you educate the woman to make sure that she is taking enough folic acid pre-pregnancy and all the way during pregnancy to prevent a neurotube defect. The most common neurotube defects we see is anencephaly, microcephaly, small brain or no brain, and then spina bifida. Some foods that are rich in folate, and you can see those are on page 345. Liver, chicken, turkey, rice, beans, lentils, asparagus, spinach. So make sure, and you know that most of our cereals are fortified, so make sure that you kind of know what kind of foods that you could tell them to use or tell them to eat to increase their folic acid. One last thing about folic acid, it is included in the prenatal vitamin. It is included in the prenatal vitamin. So they usually get their needs from their diet and the prenatal vitamin. Okay, so we want to make sure that they're getting their energy needs met. We need to calculate their body mass index. For testing purposes, you will not have the body mass index calculation, but it's important when we get patients that we do calculate the BMI so that we can make recommendations and make sure that their weight gains and their patterns of weight gain are appropriate. There are some hazards with weight gain, and when you don't gain enough, the baby obviously lacks from fats and proteins, which can cause serious central nervous system developmental problems. And then excessive weight gain for moms can cause soft tissue dystocias. When moms gain weight, they gain weight in their pelvis as well and in their vaginal area, which can cause a decrease in the ability of the baby to deliver vaginally. That's called a dystocia. And we want to make sure that they have protein, building blocks of life, and enough fluid. Of course, water. Omega-3 fatty acids are important. Fluids, we talked about water. Iron is one of the most important minerals that we need during pregnancy. Iron, because every single woman who is pregnant is literally in a state of physiologic anemia. This is because per baby she gains about 1,500 milliliters of blood volume. This blood volume, however, is only 500 milliliters of RBCs and 1,000 of plasma. So this will hemodilate the blood that she currently has, thusly decreasing the hemoglobin and hematocrit right off the bat. This is a physiologic process, however. It's a very good thing that your body does this. This is because we have that sharp rise in estrogen during pregnancy. And if we did not have this combo, the 500 to 1,000, our blood would be too concentrated and we would have a greater risk for a blood clot. So this is not patho. This is definitely physiologic, which it's a good thing, but we have to make sure that she does not get too low. We definitely want to make sure she has enough iron in her diet, and of course iron sources, dark green leafy vegetables, meats, organ meats we talk about routinely. And if we don't have enough iron, this can lead to serious poor prenatal outcomes, because if our hemoglobin and hematocrit, hemoglobin specifically, is low during pregnancy, that decreases the amount of oxygenation that gets taken from mom over to the intravillous gap. The oxygen is decreased to be pushed over. So we never want an anemic mom during pregnancy because we want baby to have enough oxygen. So we want to make sure she's eating enough iron. And then, of course, we're going to do a ton of testing to make sure that the iron levels are okay. And she will have iron in her prenatal vitamin as well. And we'll talk about that a little bit more later too. Calcium is very important. If she doesn't have the correct amount of calcium, she will deplete it from her bones and teeth. We see that quite often. Magnesium, sodium, potassium, and zinc. And magnesium, if that is low, they will definitely have a lot of leg cramping. They already have a lot of changes in the vasculature, but if the magnesium gets too low, we have a lot of cramping. Minerals, fat-soluble vitamins, of course. We really don't want them taking any extra fat-soluble vitamins, D, E, A, and K, because those are obviously stored in fat, and we know that that can cause problem during pregnancy. Water-soluble vitamins, which are mostly in you have fat-soluble vitamins, but water-soluble vitamins are the ones that we're most concerned about in the prenatal vitamin, folate, vitamin C, and your B vitamins. So this is like a really nice little cheat sheet about what you need during pregnancy. Moms need to eat 330 extra kilocalories a day per fetus. That is a textbook, and I put pretty much everything in red that's super testable. They need minerals and vitamins, iron, folate. Iron is very important because we don't want them to become too anemic and decrease the amount of oxygen that they transport to the intervillous gap to go over to the placenta and to the baby. Folate, of course, to prevent spina bifida and microcephaly. Physiologic anemia, we don't want a maternal hemoglobin less than 10. Constipation, sadly, when we increase iron in the diet, it makes moms constipated, so you're going to have to really do a good job of telling her lots of water, walking, and high fiber food in order to decrease the constipation. Ascorbic acid or orange juice, we tell them to increase the amount of absorbable iron. They should take their prenatal vitamin on an empty stomach with orange juice. Now, some people can't do that because they throw up, but this is the way you get the most iron. So make sure that you understand that, and that's in your nursing intervention toolbox. Calcium, magnesium, sodium, potassium, and fluids and water. We've already talked about that. Other nutritional things that we need to talk about is alcohol. No alcohol during pregnancy. We know that if you drink alcohol, it can cause fetal alcohol syndrome, which is a syndrome that we're going to discuss in class. That's a lifelong congenital abnormality, small brain. They have a lot of learning disabilities. So once we learned this, we stopped studying alcohol and said no alcohol. So we don't know what a safe level would be, so we say no alcohol whatsoever. Caffeine, the data remains unclear. We do know that increased caffeine in the first trimester increases the risk for miscarriages, but we don't know that caffeine plays a huge role during the pregnancy or with neonatal outcomes. One thing that is for sure is that you don't want to have Starbucks every day of your pregnancy, because when the child is delivered, the child is going to have a caffeine withdrawal headache, is going to be crying and screaming, wanting some Starbucks. So we say the general recommendation is no more than 200 milligrams of caffeine per day. No artificial sweeteners, because they haven't been studied as much as we would like. We know some of the older ones have a risk for bladder cancer, so we don't want any artificial sweeteners. And then Pica, which is interesting, in food cravings. A lot of people have these cravings for different substances. A big one is cornstarch, right here, cornstarch. What you actually say to the patient is, are you eating any non-food substances? And they go, huh? And you say, yeah, like starch, like cornstarch. And some of them will admit to you, yes, well, I eat a box of cornstarch every 3 days. Sadly, it's because they have this cravings, or because they're anemic. And it causes them to crave things like cotton balls, dirt, clay, ice, baking soda, laundry detergent, all of these things. And the problem is they're eating these substances, which could cause a bezoar in their intestine. It could cause a clogged up intestine with this non-absorbable substances such as dirt, and it can cause an intestinal obstruction. At the same time, they're not eating food to increase their hemoglobin, so these cravings continue. So you have to be really straight with people. You have to say, they come from cultures that say it's fine to eat dirt. They heard this from their mom, their grandma, and then when you say it, they're somewhat offended. They're upset because you're not going along with what they've culturally learned their whole life. And you say, well, there's dirt and bacteria there's bacteria in this dirt which could harm you and the baby. And then when you explain the whole thing out, many times they understand and they'll stop doing it. Another thing is specifically with cornstarch is they'll have a crazy amount of weight gain with cornstarch. It is more absorbable, but it is just like eating straight sugar. And so they will a lot of times put on a lot of extra weight, whereas people who are eating dirt or who are eating paper or cotton balls, they'll have decreased weight gain. Very important to talk to adolescents because, adolescents, they're just trying to do what their peer group is doing. They're just trying to eat pizza. So you have to really talk to them about nutritional knowledge and how it affects the baby. Food preparation, a lot of them don't know how to prepare food. You have to make sure that you tell them about wiping the surfaces so there's no bacteria prior to cooking the food. Also, educational programs, there are many out there for adolescents. Physical exercise, so you want to make sure that you talk to your patient. We want them to exercise during pregnancy without a doubt. This is good for them, safe for them. Most pregnancies are completely normal, and patients are taught to exercise because it's good for them and good for the baby. So you don't want them to get dehydrated, however. So you want them to make sure they drink adequate fluids. We don't really want them to break out into a sweat because once they're sweating on the outside, that means they've already burned some amniotic fluid. So we want them to make sure that they drink a lot of fluid and they're not exercising out in the hot heat and sun. We want them to do it indoors. And that their calorie intake, that they're meeting their calorie intake, which is an extra 330 per day. They're meeting those needs. Care management, the effect of a poor diet on the mom and baby it's just crazy. It can cause the mom a lifelong problems if she gains too much weight. If she doesn't gain enough weight, it can cause the baby lifelong problems. So you want to get a good diet history, health history. You want to know their usual diet patterns. Are they eating 3 meals a day? Kind of what they're doing. You want to do their body measurements, their BMI, and then of course testing and a H&H and a CBC. If people don't have enough money for food or they have limited resources, there's a SNAP program in WIC. WIC usually covers most pregnant women, even if you don't have needs. They're going to get you some food that has some iron, which is awesome to make sure that you're okay. My Plate program is a good program that kind of teaches them about how much to eat on the plate. Food safety, again, we want to talk about food safety with all moms. I'm going to talk about some specific issues in the next couple of slides, but I do want you to make sure that you talk to them about washing their vegetables before they eat them. Do not eat food that has been left out that is growing bacteria because it can cause major problems for her and the baby. And then, of course, medical nutritional therapy, that would be your prenatal vitamins all the way up to TPN. Iron supplementation, all women are supplemented with iron on their prenatal vitamins. But if their hemoglobin dips below 10, we're going to give them additional iron as well because we need their H&H to be above 10 so they can carry the oxygen over to the gap and it can be transported to baby. Nutritional related discomforts in pregnancy. So you guys, they have a lot of nausea and vomiting, constipation, and heartburn. The nausea and vomiting are from the hormones. And you guys, if they're gaining weight, the nausea and vomiting is not too bad. But if they're losing weight when they come in, we know for sure that the nausea and vomiting is a problem. And we need to talk to the provider about it to get them something. It may be Zofran to settle their nausea and vomiting, or it may even go to hospitalization depending on how much weight they've lost. Constipation, that's from the iron in the diet, and of course the uterus pressing on the colon can make them constipated. Also, not enough water in their diet, that can cause a problem. And then of course the uterus can press up on the bottom of the stomach and cause the gastric acid to reflux up into the esophagus, which is heartburn or pyrosis. So if they're having any of those, we need to talk about it so we can talk about strategies to prevent problems. Vegetarian diets, make sure that you talk to them. There's a lot of vegan diets. Consume a different diet, plant proteins, grains, dried beans, peas, nuts, seeds on a daily basis. They can get everything they need with their prenatal vitamin, but you just have to tell them that they have to be cognizant of their actual diet. Cultural influences, again, review what they're doing so that you can tell them if they have any problems. This will be on your test. Of course, this is our weight gain goals, So we want them to gain, weight based on their BMI. So if their BMI, if they're underweight, if their BMI is less than 18.5, we want them to gain 28 to 40 pounds because they're underweight. They need the fat for breastfeeding. They need the fat for nutrition. So we want them to gain 28 to 40 pounds. A normal weight patient whose BMI is 18.5 to 24.9, we want them to gain 25 to 35 pounds. An overweight woman whose BMI is 25 to 29, we want her to gain 15 to 25 pounds. And an obese woman whose BMI is greater than 30, we want her to gain 11 to 20 pounds. Now, testing wise, you will be responsible for nutritional and educational counseling on weight gain. So you're going to have to look at what trimester she's in and see if she's not gaining enough or gaining too much based on if she's underweight, normal weight, overweight, or obese. So the first trimester, we're going to use the max numbers for all of these. So let's say that when we're doing this calculation, we're going to use the max at 40 for underweight, 35 for normal weight, 25 for overweight, and 20 for obese. So as you can tell, every single one of these categories should not gain more than 5 pounds in the first trimester. This is because in the first trimester, your pregnancy is the size of a bean. And so a lot of this is fluid shifting and things of that nature. But no one should gain more than 5 pounds the first 13 weeks of this pregnancy. Now, when it comes to the second and third trimesters, what we're going to do is we're going to take the amount of weight that they should have gained. So our example, we're going to use an underweight woman, and we're going to say that we're looking at the 40-pound weight gain. So the first trimester, she should not gain more than 5 pounds, like we've said. So that would be, so we'll then take the remainder of the weight she should gain. So that would be 35 pounds. And then we're going to split that. We're going to divide that by 2, and she should gain half of that in the second trimester and half of that in the third trimester. So as you can see, for someone who is going to gain 40 pounds that was underweight, they gain 5 pounds the first trimester, 17.5 the second, and 17.5 the third. That would equal 40. So let's do one for someone who is obese. And we're going to say that she's going to gain 20 pounds. So, of course, she's just the same as all the other weight classes. She should not gain more than 5 pounds the first trimester because all the babies are the size of a bean. And then we're going to take the two remaining, the number that's left. So we'd say 20 minus 5 will be 15. Then we're going to divide that by 2, so she should gain 7.5 in the second trimester and 7.5 in the third trimester. And you'll have these kind of questions on your quiz and on your test. Postpartum nutrition, so we want them to lose the extra weight that they gained during pregnancy. We want them to gain about 5 pounds of fat during pregnancy for lactation. So their weight loss goals, if they're not breastfeeding, we want 0.5 to 0.9 kilos per week. And lactating women, not so much, like it's a quarter of that. We want 1 kilo per month. It's because we need nutrition for the baby for breastfeeding. We want them to get back to their pre-pregnancy weight. because we don't want them to carry that weight to the next pregnancy because it can be damaging to their body. Lactation needs are similar to those during pregnancy. The recommended energy intake for the first 6 months postpartum for someone who is breastfeeding is the additional 330 calories per day, just the same as you were when you were pregnant. The AAP, however, says that breastfeeding women who are well nourished should add 450 to 500 kilocalories a day. So, I just need you to know that you need to that they need to at least have the 330 kilocalories a day added. It's just that the pediatric people, the American Academy of Pediatricians, they want you to have a little bit more because babies are their focus. And a lot of times they see aggressive postpartum weight loss, and that is not good for a baby who depends on the makeup of your breast milk for growth. We definitely want adequate fluid intake. We don't want smoking, alcohol use, or excessive caffeine. Oops, sorry about that. Let's see. Okay, so the key points is we're just going to look at her diet. We're going to teach her, and we know that it's important for her and the baby. Nutrients are super important for the baby. You need to make sure that the mom gets enough iron so that baby can get enough oxygen. The weight gain is important. We don't want them to go on fad diets or have crazy ideations of not gaining enough weight during pregnancy for vanity purposes. And then of course we want iron supplementation. Food safety is super important. We don't want them to eat any food that is bad. We want patients to be very cautious about seafood, and especially we live in the South, so tuna is a high mercury fish, and it can cause fetal brain damage. So we say 1 serving of seafood a week, 2 max. We don't want them to eat any non-pasteurized meats and cheeses due to listeria, which is a bacteria that can cause serious maternal infection. It can lead to miscarriage and preterm delivery. Some of these foods are like lunch meats, vegetables that are not washed, non-pasteurized cheeses such as Mexican cheese. So we have to educate them about the listeria risk. And then the nurse and the pregnant woman, you need to really evaluate what she's eating if she is a different culture, and make sure that she has what she needs. Pregnancy complications that can be nutritionally related are anemia, gestational hypertension, gestational diabetes, and intrauterine growth restriction. So it's super important that we make sure they're eating correctly. If they're having nausea and vomiting, constipation, and heartburn, we need to talk to them and make sure that we get them on a decent diet or give them some interventions that can help them. Here's a great question. A woman at 34 weeks gestation reports that she's very uncomfortable because of the heartburn. Of course, you know the physiology behind that. As the uterus grows, pushes up on the bottom of the stomach and causes the gastric acid that's in her stomach to reflux into her esophagus. So, of course, we can't stop that. We can't do anything about it. So what can we do? Can we substitute other calcium sources? Lie down after each meal? That doesn't sound great. Reduce the amount of fiber she consumes. That would lead to constipation. Or eat 5 small meals a day. Obviously, the answer is 5 small meals a day. I'll open a discussion board on this topic, and if you have any questions, let me know. Thank you so much.